Good afternoon, everyone. I'm a clinician, so I feel very enlightened today sitting with you in the last few hours. The talks were very educational, and all the participant interaction was much more than what happens in routine conferences. So it is something outside pathology, or it starts from pathology, what I'm going to tell you. But now it has now evolved with lot of big component of genetics and applied. It's an interaction between pathology, genetics, which has helped in clinical care. So we'll see how genetics is being applied into treatment of acute leukemias. So you can all be relaxed, but I still want you to hear the lecture, just because to understand how the clinical aspects of leukemia care has evolved. From seeing the slides, looking at the morphology, from running a flow cytometry. So now when we do a bone marrow examination, we take 3 additional samples. One for the morphology, plus 3 additional tubes. 1 tube is for flow cytometry, 1 tube for karyotyping, and 1 tube for FISH. So this is mandatory even in, so I work both in government and in the private sector. So this is mandatory even for a patient who gets treated in the government sector. So it is very important that we provide tailored care. So leukemia, though, is a disease which is apparently uniform in presentation, it is not uniform in the way it responds to treatment. So there are children or adults who respond to very minimal drugs, and there are patients who require intensive treatment, including cellular therapy, for cure of the disease. So pediatric ALL, pediatric acute lymphoblastic leukemia, this is the most common childhood cancer. The survival has now reached around 80 to 90% in Western countries, and the average survival even in a country like India, where there are too many difficulties which we have to face while providing treatment, still the survival has improved to an average of 70%. So this improvement in survival is because of provision of tailored therapy. So children or adults are not dying because of drug toxicity. At the same time, they get an effective treatment also. And most of the drugs that have been used in pediatric leukemia treatment belongs to at least 6 to 7 decades back. So it is how the leukemia treatment started. The survivals were around 20%. If you see, the latest survival has improved to even 94% for the outcomes for leukemia, especially in children. And the drugs that are used are methotrexate, 6-mercaptopurine, prednisolone, dexamethasone, cyclophosphamide. These drugs are there, even the professors were sitting in the front row, they would have studied in their pharmacology. So the drugs are very old, conventional drugs, but they are still making a difference in these children in the current world. So as we'll go through the new drugs also. So the new drugs are monoclonal antibodies, bispecific T-cell engagers, chimeric antigen receptor modified T-cells, and antibody drug conjugates. So classically, B-cell leukemia is characterized as a standard risk or a high risk based on a few features. One, a child between the age of 1 to less than 10 years with a WBC count of less than 50,000 and are per se good risk by the way they are presented to the hospital. But if their genetics are available, presence of ETV RUNX1, that is also called as TEL-AML, or translocation 1221. So this, or presence of hyperdiploidy, these are the children whose outcome are 90%. Whereas for high-risk children who have age more than 10 years, who have massive extramedullary disease, big nodes, big liver and spleen, counts are very high, plus additional genetic factors like hypodiploidy, BCR-ABL translocation, amplification of chromosome 21, MLL translocation, all makes them high risk. So high risk means they are high risk for disease relapse. So those children adults are cured with intensification of chemotherapy, and if required, a bone marrow transplantation, and even with newer drugs which will be discussed in the next few slides. So children to some extent have like 50, the green ones are the ETV RUNX1 and hyperdiploidy. So 50% of children are going to have good risk cytogenetics, making them the best age group where they have a biologically good risk to get cured out of the disease. The incidence of high-risk leukemias in the pediatric age group is very less, but as the age advances, when the age goes more than 10 years and into adult age group, they start having high-risk cytogenetics commonly, including BCR-ABL, Philadelphia positive ALL, where they are going to have more the risk for relapse. So hyperdiploidy, where the chromosome numbers are more than 50, usually seen in children. As they grow older, the incidence of hyperdiploidy reduces. Again, RUNX1, ETV RUNX1 fusion, which is again common in childhood ALL, detected by FISH. Hyperdiploidy it can be made both by made out by karyotyping and by flow cytometry, which will give us the DNA ploidy. Whereas here we require FISH to identify TEL-AML or ETV RUNX1 fusion. So there are newly described fusion also, and these genetic translocations also give rise to a better phenotype. So presence of these factors are poor prognostic. Hypodiploidy, when their chromosome numbers are less than 46, it can be near haploid to low hypodiploid, and their survival can be as low as 30%. So we can still salvage these children with intensification of chemotherapy, and most of the low hypodiploid patients harbor P53 mutation. They may even harbor in their germline. So the germline, the Lee-Fromani syndrome, can manifest as in children as this type of ALL. So the presence of, once upon a time, patients with hypodiploidy underwent bone marrow transplantation, but now it has been understood that transplant really does not help them. So these children undergo intensified chemotherapy to achieve MRD negative disease. So these are the other poor prognostic chromosomal translocations. So it is very important for us to know which child harbors a bad translocation, whereas where we will give intensified therapy, where the therapy itself has the chance of creating treatment-related mortality, versus identifying children with good risk disease, where we will reduce treatment and improve their survival. So pH positive ALL, which is seen around 20-25% of adults, whereas it is just seen in 2 to 5% of children. It has the treatment has, the outcomes have improved with the addition of imatinib to the backbone of intensive chemotherapy. So nowadays newer drugs have come. So dasatinib is now no more newer. It is there for a few years, and even we have the Indian brands. So dasatinib can cross the blood-brain barrier, and it is now preferred over imatinib. So achieving a MRD, minimal residual disease negative status, and in this form of therapy, we can even avoid transplants in children. But when this disease comes in adults, irrespective of their chemo responsiveness, they are still taken up for a stem cell transplant. So there's something called pH like ALL, where it is a heterogeneous disease. There are different type of mutations that happen, and predominantly involving tyrosine kinase. So at least 50% of them harbor the CRLF2 gene rearrangements, and where drugs like JAK-STAT inhibitors, that is ruxolitinib, can be used. And similarly, when around 15 to 20% of the patients harbor mutations in ABL1, not the BCR-ABL fusion, but alterations in ABL1, and they still respond to the ABL-based tyrosine kinase inhibitors. So for every mutation, there is a druggable target present, and with availability of these targets, we are able to provide them a more focused treatment. So these mutations I have myself not seen. For this lecture, I have read about it. So for these mutations also, the HDAC inhibitors, panabinostat, can be used as a treatment. So the most spoken drug in anti-leukemic therapy in the current world is venetoclax, which is a BCL2 inhibitor. So basically, it is used in the diseases whichever we mentioned as high risk. When they are relapsed refractory, the patients are offered venetoclax as one of the treatment regimen. And so whenever there is there's no really recognizable molecular target, still we can intensify treatment by using drugs like blinatumomab, which is anti-CD19. It is a bispecific T-cell engager. So it attaches itself to CD3 of T cells and CD19 of the leukemic cell. As you all know, the common leukemia-associated immunophenotype is CD10, CD19, CD22. CD19 is almost always present. So by engaging to these two receptors, it is capable of killing the CD19 positive leukemic cells with the help of T cells. So it is almost equal to a CAR T cell therapy, which we will see in the next slide. So there are we can see there are patients who have achieved around 50% response. So these patients were destined to die. So those patients have now become salvageable with availability of these drugs. This drug is now not available in India, but it can be imported on patient basis. So it is still very expensive, but if a patient can afford, the drug is available. So anti-CD22, so we told 10, 19, 22. So inotuzumab ozagamycin is a drug plus a toxin conjugate. Where, it is a monoclonal antibody plus toxin conjugate, so which is capable of again bringing the disease in remission in patients with relapsed refractory acute leukemia who have had maybe second or third relapse. So there are side effects which are not the usual side effects seen, like presence of this is called veno-occlusive disease, which is a side effect following this drug. So CAR T cells, this is maybe the most expected form therapy for a relapsed refractory leukemia or even a high-risk leukemia upfront. So basically here the patient's T cells are taken and then it is modified with the help of a viral vector or even with an mRNA to recognize the CD19 cells. And it is then again injected back to the patient after the patient receives a lymphodepleting chemotherapy. So the brand name is Tnpciapm. So it is a CD19 targeted CAR T cells. So similar CAR T cells are available for myeloma, for diffuse large B-cell lymphomas. And here the survival of 50 to 76% are achieved in patients who otherwise had no much treatment options left behind. So there is a risk of cytokine release syndrome and neurotoxicity, which can be life-threatening. So it is like all or none. If a patient survives CAR T cell therapy, there is a high chance that he will be leukemia-free. So this is a 4-year-old girl. She was diagnosed with B-cell ALL. She received chemotherapy for 4 months. Then she defaulted. After a few months, she presented with a recurrence of the disease. Relapsed B-cell ALL does not have the same prognosis of 80-90%. The earlier they relapse, less than 18 months from diagnosis, their survival is just 10 to 20%. So with reconfirmation, the confirmation of the relapse diagnosis, she was planned for bone marrow transplantation once she was in complete remission with chemotherapy. She had severe infections. She lost hearing in 1 year following a pseudomonas infection of it was a malignant otitis externa. So her cytogenetics came after 2 to 3 weeks of initiating treatment. This is the only patient whom we have come across who had both the good risk cytogenetics, and her MRD became negative within the first month of treatment, and she is alive even today after completing her treatment without a bone marrow transplant. So the genetics of the disease speaks much more than what otherwise we understand from the disease natural course. So when we come to AML, acute myeloid leukemia, so ALL is a success story in children. In adults, the average survival is around 30-40%. Still, they require transplants for survival. Whereas acute myeloid leukemia, in all the age group, the survival is guarded. So the clinical outcome of AML is suboptimal. Chemotherapy is the mainstay of treatment, an average survival of 30 to 40%. In some good risk AML, we do get a survival of around 50 to 60%. So though it is a clinically, genetically, epigenetically, clinically heterogeneous disease, for clinician, it is only of 2 types, M3 or non-M3. M3, that is acute promyelocytic leukemia, is treated with use of all-trans retinoic acid with arsenic trioxide in a low-risk disease with addition of chemotherapy in high-risk disease. So whereas for non-M3, that is M0, M1, M2, everything belongs to us under the category of non-M3. They are traditionally treated with 2 cycles of induction followed by 2 cycles of consolidation. So though the cycle number appear less, it is one of the intensive chemotherapy a patient can undergo. They will have severe mucositis, febrile neutropenia, death because of infections. During each cycle, the risk exists. So despite all the intensive chemotherapy, their survival is 30%. To improve their survival, they undergo allogenic stem cell transplant. So this is a 19-year-old girl. She presented with fever for 3 days, past history of steroid-dependent nephrotic syndrome. So she had basically a biphenotypic leukemia. So she was, whenever we get a mixed lineage acute leukemia, we treat as ALL. If they don't respond, then we switch the treatment to myeloid. So her, both her, there was expression of both lymphoid and myeloid phenotype. Her FISH was negative for PH chromosome and for MLL translocation, but actually revealed translocation between 8 and 21. So it was an AML ETO translocation. So it was AML which was presenting as biphenotypic leukemia. It was initially new to us because for us, mixed phenotype acute leukemia has poor prognosis. They go for transplant. But then this article also says that AML defining translocation confers a favorable prognosis, that especially when there is a tendency for AML M2 to express B cell markers along with the myeloid markers. So AML, it is classified into 3. Here nothing based on the clinical scenario, everything is actually based on the genetics of the disease. So here the age doesn't matter, the extramedullary disease does not matter, the WBC count does not matter. So it is the genetics of the disease which decides the AML outcome. So favorable risk genetic translocations are 821, inversion 16, and translocation 1517. NPM and CEBPA, or these 2 mutations which is not routinely made out in a karyotyping or a FISH, we ask for a PCR. In the intermediate, the high risk is monosomy 5 and 7, complex karyotype, FLT3 mutation. All these are the routine high risk features that we see in high risk AML. Anything that does not fit into the low standard risk or high risk usually becomes a part of intermediate risk. A normal karyotype also becomes an intermediate risk. So AML, if it is a standard or good risk, they are treated only by chemotherapy. Whereas intermediate risk and high risk, they undergo bone marrow transplantation for consolidating the remission. So other than this, is there anything that we can do for AML? So the new drugs in AML are not very much followed as for ALL, but they are available. So we have gemtuzumab osagamycin. So this is anti-CD33 antibody which is conjugated to the toxin calicamycin, and it is useful in relapsed refractory AML. Nowadays it is being added even upfront in AML therapy. So for FLT3 mutation, we have drugs like midostaurin. Sorafenib is used as a FLT3 inhibitor. Now we have specific FLT3 inhibitors. The previously mentioned are multi-kinase, it is multi-targeted tyrosine kinase inhibitors, whereas we have specific FLT3 inhibitors also coming into the market. So this is the most important drug used in elderly AML, azacitidine and decitabine, especially in combination with venetoclax. So venetoclax is now playing a major role in relapsed refractory ALL and AML. So vaccines are also being tried. Vaccine against WT1 peptide. So these are the list of targeted drugs which are coming in AML. They are not used routinely except for the drugs that we mentioned like azacitidine along with venetoclax. The rest of the drugs like midostaurin is available, it is being used. Sorafenib is available, it is being used. The other drugs that oral azacitidine is available. So the drugs like IDH1, IDH2 inhibitors are not yet available but are maybe soon available in India, and they will also play a role in when we know the genetics of the disease. So from single gene mutation, we will be looking maybe 80 gene mutations in a next like a NGS panel. So that is what we are heading towards in treatment of relapsed, refractory and high-risk leukemias. So conclusions, though there are encouraging results with targeted therapy, it is often used in the setting of elderly AML or in patients who are ineligible for chemotherapy. Long-term survival is still suboptimal, especially when they are not able to undergo intensive chemotherapy followed by a stem cell transplant. So I think if we all work together more and more, we will come with newer drugs. So Sidney Farber, as you all know, he is a pathologist. He founded the first anti-leukemic drug, methotrexate. So you can walk through us in this journey to take care of patients with acute leukemia. Thank you.
Thank you, ma'am. We request Dr. Swaminathan sir, Professor and HOD, Department of Pathology, Tirunelveli Medical College, to honor Dr. Aruna Ranjithan, ma'am.
We request Dr. Parak Darab sir, Consultant Pathologist, Dr. Darab's Diagnostic.
I would like to be thankful to organizing committee of Tapcon, as well as my friend Dr. Srinivas in inviting me to share my experience. I have been in private practice for last 28 years. 30 years ago, I completed my MD, and let me tell you, I have been attending some of your lectures. My studies were much simpler. I mean, with the kind of genetic mutations and rest of the things you have to face. So what I am going to talk about is basically very simple. Clinicians and nowadays most of the laboratoricians, including pathologists, they have resigned to consider that instrument-generated results by automated instruments are as good as finally authenticated or validated reports. But bear in mind, it carries a risk when you totally rely upon instrument-generated results. And that risk is of missing the early diagnosis of the disease. And I'll be sharing with you certain things. Regarding this case, this happened around 8 years ago with my friend who was 48 years at that point of time. This was a wake-up call for me, and that really showed me how this basic thing in pathology we talk about, making early diagnosis with the screening tests, how it can get affected if the person is totally reliant upon the instrument-generated results. It is true for all the equipments, but right now I am going to focus on the hematology equipment, which is the basic CBC, that is blood cell counter. My friend presented with fever, body ache, malaise, and in monsoon. I'm sorry I cannot share with you his second day result because I don't have with me. But typically there was leukopenia, thrombocytopenia was there, and of all the things the clinician had asked, dengue antigen as well as dengue antibody. And dengue antibody IgG was positive, rather weak reactive. The patient was labeled as dengue positive patient, and they started the treatment. After around 5 days, after around 6 days, the patient started complaining of bleeding gums. So he was sent to the laboratory where the first CBC was carried out. Now, if you have seen, this is on a 3-part automated cell counter, the report was generated. Again, since the platelet count was less than 10,000 or hardly 8,000, patient had come in the evening. So patient was called next day for confirmation. Patient was still at home. See how fast we are working. And next day, again, if you see hemoglobin is 8, the difference from WBC is 3.7 to 6.6, and 8,000 and 37,000. This was only the change. So his general practitioner asked him to get hospitalized. At that point of time, he called me. I asked him to send a photo, and he sent me these 2 reports at that point of time. Looking at the reports, I said, patients, understand one thing, you get immediately admitted to the hospital and you require a further hematological workup. Sadly enough, after getting admitted, again patient followed up with the same laboratory. If you see, WBC count was 49,100. HB was 9.1. Platelets were increased. But throughout, everybody had missed something, and that was the script which was at the top of this automated report. It is mentioning SCH, G1, G2, G3, and M2. All these things, or the script, is what is called as the flagging or flag or alarm. This was the wake-up call which was given by the instrument, which the pathologist as well as the clinician did not look at or did not take cognizance of. So coming to what is flag? Flag is something like a sign or a message which automated lab equipment is trying to give to you or to draw attention of user towards a possible abnormality or an error. Now understand one thing. If we can't pick up the abnormality just based on the results of 3,700 WBCs, the machine was trying to tell us that please have a look at something. But it is exactly like a traffic signs. Traffic signals, we just look at them, and if the constable is not there, we just cross over and go ahead. And this is when I realized that most of us are not taking cognizance of the flags which are being presented to us by laboratory equipments, and we need to look at it. And that's why the topic is regarding these are the flags, these are the alarms which have been set for the laboratorician or user to wake us up. And if we don't take cognizance of it, we are bound to fail, and we are going to fail our patients. Patients are God. So we have to look after their safety. So what is, you have understood what is flag. What is its utility? Flag messages are resulted from a sophisticated analysis system which indicates qualitative or quantitative abnormalities. How does it help? It helps us in filtration of our work. So it helps us in improvement of lab time and cost efficiency. You can decide, looking at the flags, looking at the scatter plots, whether you need to go for a smear review or not. And it has been seen that the efficiency improves drastically by 60 to 80% when you are aware of the flags which are being generated by the machines. You can find out that what possible abnormalities you are going to see in the smear. I'll be sharing those cases also where looking at the flags, looking at the looking at the scatter plots, you can work out that what kind of abnormality might exist in the CBC. So what are the different types of flag? Now everybody knows whether there is lymphocytosis, lymphocytopenia, neutropenia. So whatever based on reference ranges which you have put in the lab equipment, the equipment is bound to give a L flag or H flag. So that is one type of flag where the results exceed the normal parameter limits. But what is most important from a pathologist point of view is zonal or priority alarms. Flags which are linked to an abnormal morphology in the blood cell population. They are based on the histograms, the scatter plots, and they tell you whether a particular population of cell is digressing from its normal behavior or normal place within the matrix or the histogram. That also we'll see in detail in next two slides. Analyzer alarm. Now it's a machine. It can fail anytime. A single clot, degenerated sample, problematic sample integrity, might be the lysers, the diluent. There could be any problem which might be occurring in the analyzer. The analyzer tells you, please reject the analysis. Don't use these results for final authorization. These are analyzer alarms. Then there is statistical functions like X bar B functions, which can help you in quality control. And then there is delta check. Does anybody know what is significant difference or reference change value or critical difference? What does it mean? Most of you will not, because you have not come into clinical practice or worked with equipments. Your life is going to be like that. Can you tell me that WBC of 10,000, a patient has got WBC of 10,000. Second CBC, same patient, gives you a report of 11,000. Does it mean that the number of cells have increased? Is it significantly different result? When will you call it a significantly different result? For WBCs, let me tell you, it is from 10,000, if it is going to beyond 13,500, then it means that it is a significantly different result. That means if I keep on running the same sample on the machine again and again, I may get any value between 10 to 13,000, and that will be the same value. Something of that sort, all these things. So that is a part of flagging. So if it is going beyond a specific critical difference or significant difference, it will get flagged if the patient is having the same number. So it can be tracked out. This year it's 2022. The presence of flag and its cognizance was taken first time in 2005 by ISLH. What is ISLH? It is International Society for Laboratory Hematology. And they suggested actions according to the flags or the abnormalities which can be possible. And they came out with this action criteria, which is this criteria or ISLH guidelines in 2005 itself. But still, I am talking to you about it in 2022. You can find it or Google it and you can get all these criterias. There are 41 criterias in toto, and it helps you to make decisions whether you want to see the slide, whether you should be spending the time on smear review or not. So to simplify the entire protocol, this is what is going to happen. Once the CBC is run, have a look at the data. If the flags are present, you need to prepare a blood smear for blood smear review, and then there is going to be final authentication by the pathologist. If the flags do not exist, based on the validity settings, validation settings which you have set in the machine, then that report can be just released through automated release system. This is what should be happening, but what is happening is today we are having blind faith on the instrument, or rather ourselves, and we are relying totally upon the instrument without looking at the reports generated. So this is a three-part differential cell counter WBC histogram. Have every one of you seen this anytime? Can you raise the hands? Okay. Now 3-part differential and 5-part differential cell counter. The basic concept is same, that there is like a manual thing. When you want to do WBC count, you need to lyse RBCs, remove them, and just have the look at whether in Newberg chamber or in 3-part differential counter or 5-part differential counter, have a look at those particles or those cells and make counting possible. Same way in 3-part differential it occurs, but along with the lysis of RBCs, the lyser drills holes in the cytoplasmic membrane of WBCs. And that cytoplasmic membrane, it collapses against the nucleus along with the granules. Obviously, the agranulocytes, they don't have granules, they have got round nucleus. So they are going to be somewhere, which is the smallest cell, the lymphocyte. It equals to around RBC diameter, isn't it? That's how we identify. So that helps to differentiate the WBCs into 3 main classes. One is small cells. Second is mid-size cell population, and then large cell population. Large cell multilobation of which is seen in neutrophils. So granulocytes are differentiated in this area. If you see 150 femtoliter to 400 femtoliter, it will be all granulocytes. So what do you find less than 50? Which particle is less than 50 femtoliter in size in blood? Understand, machine is picking up only the particle. You are calling it a cell. So the particles are platelet aggregates, or it could be nucleated RBCs, because now RBC membrane is stripped off, or there could be malarial parasitized RBCs, because they also are lyse resistant in nature. Now, since 1999, I had been using Horiba cell counters. So my slides will be related to their scatter plots as well as their histograms are about the flags. But same concepts can be extrapolated towards any other 3-part or 5-part cell counter. So if there is significant cellular events or abnormal population which is going from this small cell area towards mid cell area, either it can be monocytosis metamyelocytes can be present. There could be lymphoblast in this, and accordingly, the machine gives you M2, G1, G2, and G3 flaggings. So if you are aware or have knowledge of these flaggings, you can start picking up the abnormal cell population just looking at these histograms and comparing it with whatever results you are getting on the instrument, and then deciding whether to do slide review or not. This is a 5-part differential cell counter scattergram which presents the Wbc differential matrix. Here the lyser acts in a different way. It lyses RBCs, but the cytoplasmic membrane does not collapse. It remains intact over there. So obviously, presence of nuclei as well as the granules will cause obstruction to the light, and there is going to be a light loss. The size of the cell is on the x-axis. So the smallest cell with minimum light loss is going to be your lymphocyte. Then there is neutrophil. Then there is monocyte. It is largest, but the light loss is same. And then there are eosinophils. Now everybody talks there are multiple cell counters. So how will we be able to extend the same concept to another cell counter? So this is a Beckman-Coulter cell counter. Here there are lymphocytes. Here there are neutrophils. They are totally in different position than this. And you feel that the matrix is totally different. But it is not so. The same, this figure, I have changed it, just rotated it, and you will see there is no practical difference between the different matrices from different instrument. In the manual, you will get information about alarms and what do they mean or what is the suspected pathology, just like the way I have presented it over here. Dr. Sukesh Nair came out with a very good terminology, hemocytomorphometry, where the numbers as well as the matrix and scatter plots as well as the histogram, the study and correlation, he started calling it hemocytomorphometry. This is a case, as I told you, here is the lymphocytic cluster, here is the neutrophilic cluster, but there is abnormal cell population which has been flagged off over here. So what it could be? Here, if you will see, on the peripheral smear, you can see the presence of NRBCs. Now, presence of these abnormal population with a flag, the person should immediately look at the peripheral smear, and you can then diagnose and rectify falsely high counts of WBCs. Similarly, abnormal cell population, polylobated neutrophils. So one can, looking at these matrix, one can extrapolate that there could be polylobated or hypersegmented neutrophils present in this sample, which is not given in your instrument generated result at all. Heavy abnormal cell population, you can see blast cells over here. I'll just skip it, the cases. Likewise, there are system flags, and this is case of infectious mononucleosis with lot of atypical cells one can make out. This was a case of acute lymphoblastic leukemia. Again, look at all the system flags which were given. Looking at this banana-shaped cluster, which is mixing of lymphocyte and monocyte, one can say that the blasts are going to be lymphomonocytic origin. So one needs to look at it from that angle when he is looking at it, the peripheral smear. This is a neutrophilic zone. This is a monocytic zone. The neutrophil and monocyte clusters are intermingling. This was acute myeloblastic leukemia, which was proven later on. This was again the similar case. Now, this was something which I was working for last 4 to 5 years, more than 5 years. Malaria and dengue is very common in our Indian subcontinent. What it's seen is maybe the abnormal population sometimes, but the mainstay or the gold standard is still looking at the peripheral smear. And it was very time consuming to keep on looking at the peripheral smear. Right now in African countries, they are talking about submicroscopic level malarial infestation. So looking at that, I felt whether we can use artificial intelligence which can pick up multiple minute points from the CBC readings. And bear in mind, these are not just the 22 parameters or 18 parameters which you see on a CBC report, but it considers the scatter plots, all hemocytometry we talked about. So we process the data in this way using artificial intelligence and machine learning. We used consecutively for 4 years, we were collecting data with positive samples using malaria rapid diagnostic test, malarial smear screening, doing dengue ELISA in each positive as well as negative sample, collecting more than 8 to 10,000 samples. And we came out with a probability score, which tells you about that. It gives you an objective reading where it's like tossing a coin. You say that either it could be heads or tails depending upon the 50% area. So we took the cutoff as 0.5. Anything beyond that, between 0.5 to 1, gives you a higher probability score that this infection exists in the machine. And it really helped during COVID. 65-year-old was admitted in medicine care unit. The CRP was 200 milligram. And looking at the neutrophil lymphocyte ratio when we had nothing about it, what we found out that there was a flag which was raised with P-Vivax. The probability was 0.96. You can see Vivax malaria over here, which was proven on rapid diagnostic test.
Excuse me, Dr. Parag.
Yeah, this is last slide. Similarly, for Plasmodium falciparum, we could pick up a similar result when the COVID was suspected. So, understand one thing, all of you postgraduates, 80% of you are going to go in private. And in private, all these things become essential. So better be aware of these things which you don't learn during your medical education. Thank you very much. I know it is very tiring day. Thanks.
Thank you, sir. We request Dr. Swaminathan sir, Professor and HOD, Department of Pathology, Tirunelveli Medical College, to honor Dr. Parag Dharab sir.